Hello and welcome back everyone to this next episode in the series of drugs that are used in arthroplasty patients. In this episode, we're going to discuss about the treatment guidelines for osteoporotic therapy. I- In the video, first let's look into the screening criteria for initiating the osteoporosis management. So, any patient who is more than 60 years female or any patient who is more than 65-year male, osteoporosis screening can be advised, and postmenopausal women less than 60 years or males 50 to 60 years age group with associated risk factors for fractures, and any patient less than 50 years with fragility fracture, or patients who have rheumatoid arthritis, diabetes mellitus, malabsorption, and those patients who are on high dose long term glucocorticoids are screened for the osteoporosis. Now, how do we screen these patients? By doing blood tests and some imagings. So, in the blood test, we do CBC, calcium, phosphate, alkaline phosphatase, renal function test, liver function test, vitamin D, parathyroid hormone, and thyroid stimulating hormone, and ESR and electrophoresis to rule out multiple myeloma. And to quantify the bone mineral density, we do dual energy X-ray absorptiometry, DEXA scan, and this gives T score and Z score. And few other investigations for screening are the bone turnover markers, that is type 1 collagen C telopeptide, procollagen type 1 N propeptide may also be advised in these patients. And FRAX tool gives the 10-year risk of hip fracture or any major osteoporotic fracture. However, utility of FRAX tool in Indian population should be done with caution because of lack of data. Now, few points about indication for initiating osteoporotic therapy. Therapy is initiated in those patients who are more than 50 years with T score less than minus 2.5 and T score minus 1 to 2 minus 2.5 associated with risk factors or 10-year probability of hip fracture more than 3.5% and major osteoporotic fracture risk of more than 10.5%, and in diabetics with T score less than minus 2 and patients with history of fragility fractures fit into the criteria for indication to start the osteoporotic therapy. So, when we look into the first line therapy for high risk patients without prevalent underlying osteoporotic fractures, we initiate with calcium and vitamin D supplementation, and bisphosphonates are the drugs of choice here. It can be either oral alendronate 70 mg per week or parenteral zoledronate yearly. If there is a reaction to bisphosphonates or bisphosphonates are contraindicated, like in cases of chronic kidney disease in advanced stages, denosumab may be advised 60 mg once in 6 months subcutaneous dose. And if patient has very high risk of osteoporotic fractures or T score is less than minus 3.5, teriparatide might be initiated 20 mcg subcutaneous. Intranasal calcitonin has only shown to benefit for temporary bone pain relief. Now, a few points about the combination and sequence of the therapies. It is shown that the bone mass is significantly higher when teriparatide and denosumab are given combined in comparison when they're given separate. And teriparatide therapy should be followed by anti-resorptive agents to increase the efficacy of the bone mass that has been gained. And denosumab should be followed by bisphosphonate therapy because discontinuation of denosumab beyond its due date has shown for increased rebound fractures of the vertebrae. And these patients should be followed up 3 months after initiating the therapy, then 3 to 6 months interval for 2 to 3 visits, and then annual visits. And in every visit, Clinical examination and laboratory investigations like vitamin D and imaging with BMD should be done every 1 to 2 years. And it is said as treatment failure if loss of BMD over 2 years of more than 5% in lumbar spine and femoral neck. And one may also do the bone turnover markers at baseline 3 months, 6 months, and 12 months to see and assess the efficacy of the treatment. So, drug holiday is not recommended in very high and high risk group of patients, and it may be given or utilized in moderate to low risk patients. If drug holiday is advised, then these patients should be assessed for risk of fracture at every 2 to 4 year interval by assessing all the parameters that we discussed earlier. And patients who have a risk of osteoporotic fractures should always be educated about fall prevention, and that could be advice about footwear like low heeled shoes with rubber soles, and avoiding walking on slippery floors, and having handrails and utilizing handrails while ascending and descending the stairs, and keeping the rooms, bathrooms, and stairs well lit. And one may also use in-room carpet, and especially in the bathroom walls it is advised to install and utilize the grab bars for these elderly patients to prevent fall and thereby osteoporotic fractures. So as an arthroplasty surgeon, it is very important to know the treatment guidelines for osteoporosis to prevent periprosthetic fractures. And here is the reference for this data presented in this video. Thank you.